Hello everybody, Namaste. Today we are here to discuss on the topic pre-renal, renal and post-renal disease and its differential diagnosis. So shall I start? Okay. As you know that acute kidney injury is defined as abrupt onset of disease within a short period of time, maybe within hours or day. And the spectrum of disease may vary from mild to the severe form, and sometimes may require renal replacement therapy. So let's think about it from diagnostic point of view. For diagnostic evaluation, acute kidney injury can be classified as pre-renal, renal and post-renal disease. So here is the table showing the information about pre-renal, renal and post-renal disease. And let's discuss it one by one. Coming to the first pre-renal one. Pre-renal means problem in before the kidney. That means problem maybe in heart, maybe in liver, maybe in GI tract. Okay. And next one, renal. Renal, the problem is inside the kidney. Okay. That means the problem can be in nephron. Right. And finally, the post-renal one. The problem is downstream to the kidney. That means problem can be in ureter, can be in urethra, can be in bladder, or can be in prostate of male. Okay. So let's discuss what actually happens in this disease. So what happens in pre-renal disease? In pre-renal disease, there is decreased blood flow. Decreased blood flow means decreased perfusion to the kidney. And ultimately, there will be decreased GFR, glomerular filtration rate. And in renal disease, there is intrinsic damage to the kidney. And damage can be in glomerulus, or it can be in tubule of the kidney, or it can be in interstitium of the kidney. Interstitium is the part which consists of cells, matrix, and peritubular space or intratubular space. Okay. And in post-renal disease, what happens actually is the obstruction. There can be obstruction in urinary tract. Right? Now let's discuss about cause of this disease. And coming to the pre-renal one, the pre-renal cause, here are the list of pre-renal cause. The first one is low blood volume. Low blood volume can be due to dehydration, blood loss, or due to any other reason, which can be the cause for pre-renal damage. And the heart failure. In heart failure, heart is unable to pump the sufficient amount of blood to the kidney, which can cause pre-renal kidney disease. And liver cirrhosis. Liver cirrhosis followed by portal hypertension, followed by decreased cardiac output, and the collection of fluid in the abdomen can cause the pre-renal disease. And there is the group of drugs known as RAS blocker, renin, angiotensin, aldosterone system blocker. This consists group of drugs which are ACE inhibitors, angiotensin receptor blocker, and renin inhibitors. These drugs collectively will decrease the intraglomerular pressure, and which will ultimately decrease the GFR, which can be the cause for pre-renal disease. Now, coming to the cause of renal disease. Renal disease, the damage can occur to glomerulus, it can occur to the tubule, and it can occur to the interstitium. Okay, so glomerular damage can be caused by autoimmune disease such as systemic lupus erythematosus, SLE, multiple sclerosis, and medication of arthritis. And damage to the tubule can be due to trauma, physical stress, can be due to rhabdomyolysis, destruction of muscle, can be due to tumor lysis syndrome. Tumor lysis syndrome means lysis of tumor cell by medications. The features of rhabdomyolysis and tumor lysis syndrome are almost same. And what happens is that due to the excess lysis of cell, there is deposition of phosphate, potassium, uric acid in the blood, which are the culprit for the renal damage. And renal ischemia. In renal ischemia, there is decreased blood supply to the kidney, which can be due to the poor blood vessels or damaged blood vessels, or which can be the effect of pre-renal disease also, because pre-renal disease means decreased blood flow, which can cause renal ischemia. And finally, the damage to the interstitium can be caused by drugs such as proton pump inhibitors, such as pantoprazole, omeprazoles, antibiotics such as aminoglycosides and vancomycins. Now, coming to the cause of post-renal disease. Post-renal means after the kidney. So here are the list of cause. The first one is enlargement of prostate, can cause obstruction. Bladder stone, cancer of bladder may also cause obstruction, and retroperitoneal fibrosis cause the obstruction in ureter. So friends, this is the general information regarding the pre-renal, renal and post-renal disease. Now we will discuss about differential diagnosis of this disease by the aid of biochemical parameters. Okay, let's talk about differential diagnosis of pre-renal, renal and post-renal disease by the help of biochemical parameters. Here I am going to list out parameters. Blood urea nitrogen, creatinine, urine sodium, fractional excretion of sodium and urine osmolality. So by the help of these parameters, we are now going to differentiate pre-renal, renal and post-renal disease. As you all know that blood urea nitrogen and creatinine are also known as nitrogenous compound, which are present in our blood. And if this nitrogenous compound accumulates in our blood, the term is known as azotemia. Azotemia means excess accumulation of nitrogenous compound in our blood. Okay. So by relating with this azotemia, the kidney problem can be classified as pre-renal azotemia, renal azotemia, and post-renal azotemia. Okay, so we are using this parameter to differentiate the kidney disease. The another thing is that the relation between bone and urea is bone times 2.14 equals to urea. So urea and bone are the same things. You can calculate. And another thing is that FeNA means fractional excretion of sodium, and it is calculated as 100 times urine sodium multiplied by serum creatinine, serum sodium multiplied by urine creatinine. This is the formula to calculate the fractional excretion of sodium. Why it is important? It is important because it helps to differentiate pre-renal from renal disease. It helps to differentiate pre-renal from renal disease, and it is expressed in percentage. It is expressed in percentage. Okay. Now let's discuss about these parameters in different diseases. First, I am going to discuss these parameters in pre-renal disease. Pre-renal disease. In pre-renal disease, serum to creatinine ratio, urine sodium, and then FeNA, and then urine osmolality. It will be greater than 20. It will be less than 20 millimole per liter, and it is less than 1%. It is greater than 500 milliosmol per kg. Now we will discuss how it happens, the reason behind this in pre-renal disease. Okay, we will try to interpret this value in pre-renal disease. So let's start from diagram. Here I am making the diagrammatic representation of nephron of the kidney. This is just a diagrammatic representation to explain you the reason behind this. Okay. Now we are talking about pre-renal disease. This is afferent arterial, this is efferent arterial. In pre-renal disease, we have seen that bond to creatinine ratio is greater than 20. So, how it happened? So, let's talk about it. The normal function of kidney is to filter the bond, to filter the creatinine. Okay? And we know that bond get reabsorbed. And finally, it will go to the blood. Now, in pre-renal disease, there is decreased blood flow. Decreased blood flow. Decreased blood flow means decreased GFR. So, what happens is that if blood flow is low, the flow is inversely proportional to reabsorption of urea. Reabsorption of urea. The flow is inversely proportional to reabsorption of urea. That means if flow is low, the reabsorption will be more. The GFR is low here, blood flow is low, ultimately the flow will be low. If flow is low, the reabsorption of urea is more. That means more bond get reabsorbed and more bond in blood. That's why bond to creatinine ratio is greater than 20 in pre-renal disease. Now coming to the next parameter, urine sodium less than 20 millimole per liter. How it happens? Now forget about bond and creatinine. Urine sodium less than 20. Again we know that in pre-renal decreased blood flow. Decreased blood flow means decreased blood pressure. The decreased blood pressure is sensed by our body and the renin, angiotensin, aldosterone system gets activated. Okay, it gets activated. When this system gets activated, they cause increase in aldosterone, and also the ADH, antidiuretic hormone. When aldosterone get increased, it will reabsorb the sodium from the tubule along with water. So increased reabsorption of sodium in tubule means decreased excretion of sodium in urine. That's why it is less than 20. Similarly, FeNA is less than 1%. Since it depends on total urine sodium, if the urine sodium is less than 20, it will be less than 1%. Okay, we have already talked about formula of FeNA. Now coming to the final one, urine osmolality greater than 500. That means more. How urine osmolality is greater than 500 in pre-renal? As you know that when aldosterone get increased, it will reabsorb water and sodium. ADH get increased, it will reabsorb more water. So overall, more water get reabsorbed in the tubule means less water in urine. Less water in urine means more osmolality. Okay. Now discuss about renal cause. What happens in renal one? renal. And renal 1, bond to creatinine ratio will be 10 to 15. Urine sodium will be greater than 20 millimole per liter. Okay, unit is same. Since it is ratio, there is no unit here. In FeNA greater than 2% and urine osmolality less than 350 milliosmol per kg. Now discuss about the reason behind it. Same thing. Normally, bond get filtered, creatinine get filtered, bond get reabsorbed. But problem is that in case of renal, there is a damage. Damage can be in glomerulus, can be in tubule, can be in interstitium. Okay? So, if there is damage in glomerulus, bond and creatinine doesn't get filtered. Means no change in ratio. This is the one point. The another point is that if damage in interstitial tubule, this tubular cell, if damage in interstitial tubule, there will be no reabsorption of urea or bond. There will be no reabsorption of urea. No reabsorption of urea means no urea in blood, no more urea in blood, and ultimately ratio will decrease or shift toward 10 to 15. Coming to the second point, urinary sodium greater than 20. Okay, urinary sodium greater than 20 means in this case the damaged tubule cannot reabsorb sodium. Damaged tubule cannot reabsorb sodium. If damaged tubule cannot reabsorb sodium, obviously it will increase in urine. If urine sodium increase, then fractional excretion of sodium will increase. Okay. Coming to the final point, urine osmolality less than 350. Urine osmolality less than 350. That means that if tubules get damaged and more damage, the concentrating ability of kidney is lost. That's why the osmolality is less. Now coming to the final disease, post-renal disease. What happened in post-renal disease? Let's discuss about it. The post-renal disease, bond to creatinine ratio will be 10:1 to 10:1 to 20:1. Urine sodium will be greater than 40. And fractional excretion of sodium will be 2 to 4%. And urine osmolality will be less than 350. So let's discuss about the reason behind this. Okay, this is post-renal. So let's discuss the reason behind this. How this happened. As you all know that, same thing, bond get filtered, creatinine get filtered, bond will reabsorb. This is the normal phenomenon. Now what happened in the obstruction? There will be the obstruction to the flow of urine. This is the obstruction. So during initial phase of obstruction, there will be little bit backflow or the pressure. Little bit backflow or the pressure. That will cause reabsorption of bond. Slightly more reabsorption of blood urea, nitrogen. And the ratio will shift toward upper end of reference value. Initially, the ratio will shift toward upper end of reference value because bond get reabsorbed more, slightly more. But later what happened? Due to increased continuous pressure, now this will start damaging the cell here. They will damage the cell. And later there will be decrease in reabsorption of bond. And then the ratio of bond to creatinine will shift toward lower end. Okay, initially the ratio is to our upper end of reference value because the absorption is more. Later, due to continuous backflow, the renal tubular cell may get damaged, and then ratio is shift to our 10:1 because it will decrease the absorption of 1 later stage. The second point is here, the urinary sodium is greater than 14. So how it happened? How it happened is due to increased overflow of fluid, the secretion of aldosterone is decreased. The secretion of aldosterone get decreased. When aldosterone secretion get decreased, no sodium reabsorption. That will cause increased sodium excretion in urine. Alright? If sodium excretion is more, ultimately fractional excretion of sodium is also more. Now finally, urine osmolality is less than 350. How it happens? Because the continuous backflow, it acts like a dam. So because of continuous backflow of the fluid, the tubular cell get destroyed. So ultimately, concentrating ability of kidney is lost and the urine osmolality is less than 350. Okay, so friends, this is about comparative diagnosis of pre-renal, renal and post-renal disease by the help of biochemical parameters. Okay, so thank you for watching this video, and your comments and suggestions will be much appreciated, and do not forget to like and subscribe